Can you please unmute your mic? Please unmute your mic. We can't hear you, Amit. Can you please unmute your mic?
Okay.
Yeah, thank you. Yes, please put it on
Yeah.
full screen. Yeah, thank you.
Yeah. Good evening to all of you. I am extremely thankful to Professor Kim Mammon for having given me this opportunity to participate in this webinar. And I'm the only nephrologist in this panel, so it's an additional honor for me. The medical complications after renal transplantation is a rather wide topic, and I'll try to touch briefly on some of the important aspects and talk about the more recent advances. The major complications after transplant are rejections and infections. An acute rejection has a negative impact on the long-term outcome. There has been a dramatic reduction in the incidence of acute reduction over the past 3 decades, essentially due to better immunosuppression, and therefore optimizing immunosuppression remains extremely challenging. And it is the major predictor for interstitial fibrosis and tubular atrophy. The two principal forms of acute rejection are the acute T cell mediated, which was earlier known as cellular rejection, and the other is the acute antibody mediated rejection. And both acute antibody mediated rejection and acute T cell mediated rejection may coexist at the same time in the graft. There are several risk factors for acute rejection, but the most important is non-adherence to immunosuppression. Non-compliance to drugs is probably the most important cause for acute rejection. When do we suspect acute rejection? If there's increase of creatinine by more than 25% from the baseline, or in any patient who has an increased risk for developing ABMR, has an increase in creatinine, you should suspect acute rejection. If the patient turns to have a worsening of his hypertension or the proteinuria is in excess of 1 gram per day, you should suspect acute rejection, and the gold standard for diagnosing acute rejection is, of course, doing a graft biopsy. There have been various attempts to standardize the histological criteria, and the BAMF classification has been updated from every 2 years. The latest one in 2018, where they've suggested that diagnostic criteria for ABMR have been modified, which we'll be talking about later. This acute T cell mediated rejection happens because the T cells react to the donor HLA present within tubules, interstitium, vessels, and glomeruli. And the primary lesions include interstitial infiltration with mononuclear cells, disruption of the tubular basement membrane, which is known as tubulitis. Intimal arthritis can be seen both in T cell mediated rejection and in antibody mediated rejection. The treatment, essentially, you start off with methylprednisolone. If you do not have any response, you try rabbit antithymocytic globulin. Alemtuzumab has been used in some studies, which is a humanized anti-CD52 monoclonal antibody. ABR is the most common cause of allograft failure. About 1 to 10% of recipients experience ABMR. And essentially, it occurs because of the B cells and the plasma cells get activated, which leads to donor-specific antibodies being formed. And these bind to the HLA and non-HLA molecules of the endothelial cells within the graft. And there's activation of the complement-dependent and the independent mechanisms. There's recruitment of NK cells, the neutrophils, the platelets, and the macrophages, which leads to peritubular capillaritis, glomerulitis, cellular necrosis, and thrombotic microangiopathy, and leads to rapid decline in the graft function. Then you have the C1q binding donor-specific antibodies, which are closely associated with acute antibody-mediated rejection, more severe graft injuries, and early graft failure. Whereas C1q non-binding donor-specific antibodies correlate with subclinical or chronic ABMR and late graft loss. The diagnosis of antibody-mediated rejection essentially requires 3 components. You have the histological evidence of acute tissue injury. Then you have the evidence of antibody interaction with the vascular endothelium, which is essentially seen by C4D staining in the peritubular capillaries. And then you have the serological evidence of circulating donor-specific antibodies. And patients with the first two criteria, but do not have the evidence of DSAs, were previously considered to be suspicious for ABMR. The BANF classification in 2017 was suggested that the presence of peritubular C4D staining and or the expression of validated gene panels can substitute for donor-specific antibodies in the diagnosis of antibody-mediated rejection. Again, some patients have been seen to have no morphological evidence of ABMR and yet have a positive DSA with little or no C4D staining. And C4D negative ABMR again represents antibody injury that does not activate the complicated cascade. So as you have seen that over the years, we have now changed the diagnostic criteria for ABMR because as we learn more about this condition. There are certain predictors of outcome, particularly in regards to donor-specific antibodies, and a publication in 2010 had shown that the risk of ABMR and graft loss correlated well with the peak pre-existing anti-HLA DSA levels, which is so anybody who has a DSA in excess of 6,000 had a 100-fold increased risk for developing ABMR as compared to patients whose levels were less than 500. Again, graft survival in patients with anti-HLA DSA with a mean MFI of greater than 3,000 was lower than those who had patients with an MFI of less than 3,000. Again, a publication in 2016 looked at the immunoglobulin subclass of the DSA, and which could predict the outcomes. And it was seen that IgG3 DSA associated with shorter time to rejection, increased microvascular injury, C4D capillary deposition, and graft failure. Whereas on the other hand, IgG4 DSA associated with later graft injury and increased globulopathy, etc. Again, the type of DSA, whether it was pre-existing or de novo, predicts the outcomes. Those patients who had a de novo DSA, which was related to inadequate immunosuppression, was associated with poorer outcomes as compared to ABMR in patients with pre-existing DSA. The other risk factors was the expression of the endothelial cell-associated transcripts, and this has led to risk stratification and prognostication in patients with antibody-mediated rejection. The treatment, there's unfortunately no randomized controlled trials which compare the safety and efficacy of different therapeutic strategies. Most people use a combination of steroids, plasmapheresis, and administration of intravenous immunoglobulin. Some patients administer rituximab. There are anecdotal studies with bortezomib and eculizumab, but these have not been found to be very satisfactory. The experimental therapies include activation, since there's activation of the complement pathways, and therefore it has provided a rationale for the use of proximal complement inhibition using C1 inhibitors in the treatment of ABMR. And one of the studies published in 2016 had shown, this was a phase 2 trial, which has shown there's a trend towards sustained improvement in graft function at day 90 in the group that was given C1 ion channel. Now we'll talk briefly about infection, which is the other complication that we can see after transplantation. And as you can see from this graph, the infection episodes increase as with time. The post-transplant infections are they different? They have a diverse etiology. They are caused by atypical organisms. They can be found in atypical sites. There's blunted inflammatory response. The serological tests are not generally helpful, and the diagnosis requires imaging, tissue biopsies, and occasionally surgical interventions, for example, if you have mucormycosis. Transplant patients are susceptible to both common and opportunistic infection. The common infections for the respiratory tract, you can have upper respiratory infection and UTIs. UTI infection has been seen in almost a quarter of patients within 1 year of transplant. And so many patients may present with asymptomatic bacteria, uncomplicated UTI, and complicated UTI. They can be present in about 44% of the patients. Complicated UTI in a quarter of the patients, and most often this is caused by gram-negative organisms, E. coli being the dominant causative organisms. I'll talk about the viral infections because this is again increasing in numbers. So you have different types of viruses. CMV, for example, can present with fever and neutropenia. Hepatitis can be caused by hepatitis C and hepatitis B infection. CMV infection can also lead to gastritis, esophagitis, and colitis. Varicella zoster can lead to cholangitis, and you can have herpes simplex causing encephalitis, etc. Then you can have indirect effects caused by viral infections. This can predispose to opportunistic infection, for example, aspergillus or pneumocystis after CMV infection. Then you can have CMV co-infection with hepatitis C, which can lead to cirrhosis and graft loss. And if you have CMV along with Epstein-Barr infection, it can occasionally lead to post-transplant lymphoproliferative disorders. Graft rejections can be seen in patients with CMV infection. And oncogenesis, viruses predisposed to cancer or to cellular proliferation. Specific viral pathogens, BK polyoma virus, adenoviruses, uh, Epstein-Barr virus, and parvovirus. Parvovirus can lead to anemia, and therefore, if you have a transplantation with unexplained anemia, look for parvovirus. Cytomegalovirus can either lead to active CMV infection, where you can have presence of CMV replication in the blood regardless of whether symptoms or signs are present. Then you can have CMV disease, where you have presence of detectable CMV accompanied with clinical manifestations. And then you have the CMV syndrome, where you have presence of detectable viral replication in the blood accompanied by signs and symptoms in the absence of tissue invasive disease. The various antiviral drugs that are used for the treatment of CMV include intravenous ganciclovir, oral valganciclovir, intravenous foscarnet, or intravenous synfovir. We now have started seeing the problem of CMV resistance, and this is seen in almost 10% of the transplant recipients who are receiving treatment for CMV. In such situations, you need to perform a genotypic assay, and genotyping testing has been found is essentially done to identify whether the mutation is either UL97 or UL54. And more than 80% of the resistant isolates have been found to be due to UL97 mutations. And if you have a UL97 mutation, people have recommended the use of intravenous foscarnet. And those who have a UL54 mutation, you can use a higher dose of ganciclovir in the dose of 10 milligram per kilogram intravenous every 12 hours. The newer antiviral drugs which have been used for CMV are letermovir, maribavir, and brincidofovir, which are now being tested and which should be available for clinical use in the near future. Again, there is this discussion about whether we should prolong the duration of treatment which we give for as prophylaxis against CMV. Generally, prophylaxis for CMV is given for 3 months, but there was this paper in 2010 which suggested that if you give it for a longer period of time, for as long as 6 months, perhaps you could reduce the incidence of CMV disease in future. A few words about BKV. BKV, there is usually a reactivation of latent infection, which can lead to viruria in about 25 to 30% of the patients, viremia in about 12%, or graft nephropathy in 1 to 10%. And there's several risk factors in the immunosuppression, donor who's carrying this BK virus infection or viruria prior to transplant, elderly individuals, ABO incompatible transplants. If your patient is having a urethral stent, delayed graft function or rejections are other risk factors. The incidence is highest in the first 2 to 6 months, but can occur years after transplantation, and it can lead to progressive graft dysfunction and graft loss. It can lead to interstitial inflammation, fibrosis, and tubular injury. And essentially, if you do a biopsy, you can see intranuclear basophilic viral inclusions without a surrounding halo. And you can see tubular injury, which leads to tubulitis. And when extensive tubulitis is difficult to differentiate from graft rejection. And here you can see the amorphous basophilic ground glass inclusion body, which is the most frequent form. The treatment, you try and reduce the immunosuppression, which is actually the cornerstone of treatment. You can try intravenous immunoglobulin. Leflunomide, majority of the studies have not found any benefit. Cidofovir, again, should be considered only if other interventions are failed. Remember that it is potentially highly nephrotoxic. quinolones, which many of us use, again, most studies have shown that it does not reduce the viral load at 1, 3, or 6 months. Occasionally, acute rejection and BK virus nephropathy can coexist. So if you have a combined presence of endarteritis, fibrinoid vascular necrosis, glomerulitis, and C4D deposits along the peritubular capillaries, they can suggest a concurrent rejection. Should we retransplant patients who had BK virus nephropathy? It is suggested that you must wait till the BK virus viremia has completely resolved, and you must confirm this replication before you do a transplant. In such situations, try and avoid intense immunosuppression. Whether we should take out the graft from the old graft, again, it's been suggested do not routinely perform nephrectomy of the failed graft or the native kidneys, although there's no definite consensus. One last word about the emergence of gastrointestinal microbiota and transplant-associated infections. It's been seen that gut microbiota is a potential source of infection in immunocompromised patients and lead to bacterial, fungal, or protozoal or viral infections because gut microbiota are linked to immune regulation, metabolic modulation, and drug absorption. And this gut microbiota gets altered in the post-transplant period. And it's been seen that there's a higher fecal abundance of enterococcus, which can lead to enterococcal UTIs. Also, because of this altered gut microbiota, there could be a high incidence of acute rejection. So this is another area that people are looking at, which can occur in post-transplant situations. So in summary, I would say acute rejection is one of the most important medical complication in the transplant after renal transplantation. Two principal forms are T-cell mediated and acute antibody mediated rejection. Infection remains the other major complication that we see and is determined by the synergy between two factors, the epidemiologic exposures and the net state of immunosuppression. Thank you very much for your attention.